I think first and foremost, what's, at the end of the day, the field is moving so fast. All fields are moving so fast. And I think it's just imperative that we all learn from each other. And so, like I said, I know a number of you are not radiation oncologists and you're interested in learning more about it. And I think ultimately, the more we learn about each other's therapies, the more that we understand the nuances related to not only the ability to cure disease or to improve outcomes, but equally important is to our patients are living longer. So it's really important that we also understand what are the toxicities, both acute and chronic, that can influence, our subsequent therapies. And, I think where the future is integrating, as I'll get into here a bit, is really, it's not looking at it from what can I do for the patient, but it's what can we do for our patient, and making sure that we're thinking ahead, looking, our patients now with immunotherapy and other things are living longer. And today, admittedly, I'm going to focus a little bit more on the role of radiation, but I'm going to speak to, a little bit of how we integrate with other therapies, and also to start thinking about, what is the future? How do we develop the best trials? And I really think that when we think of protocol development, we tend to still think somewhat, within our own field. And I do see the future as being really much more multidisciplinary, much more integrated. And again, for that reason, I'm honored to be able to talk with you about this today. And hopefully, again, there'll be some additional thoughts and interest in terms of future management of your patients. Just acknowledging some of my disclosures. I've done some clinical research consulting, and I've helped do protocol development on a number of different protocols over the years. And currently, I have done some work for Boston Scientific, BTG, and Histosonics. And as mentioned, I do have a grant from the 1440 Foundation, which is a private foundation, to create a learning health network for pancreas cancer, which is not related to this, but just relevant. Here are the areas that I'll be speaking to today. I'm going to get into first, what is the role of radiation in HCC? I have lots of pictures to try to keep people focused. And then also I'll be jumping into some of the, just sort of, I want to give you an overview of what exactly is radiation, how is it given? And then I'm going to get into HCC specifically and some of the nuances and some of the use cases and how it compares to RFA and TACE. And then finally, I'll just touch a little bit. I think the role of, although I know we're focusing mainly on HCC, I think more and more patients are living longer, and we're all having to manage, the acute, sort of recurrences, and also some of the toxicities that are associated with chronic chemotherapy, radiation, and just kind of making sure that you have some sense of what radiation can cause. And then a couple slides on just, future directions moving forward. So I think many of you know this, but I don't know if, if we always think about it this way. And I think, again, I challenge all of us to, during multidisciplinary tumor boards and clinics, is to take a step back and really ask the question, what do we think is going to be the most durable outcome for the patient that's in front of us? And I think, we can all agree that transplant for HCC and or surgery still has the best outcomes, but we admittedly, it's a small proportion of the patients we typically discuss. So then the next is, what are the other types of local therapies? And I'll be speaking primarily about stereotactic today. I'll talk a little bit about radioembolization. And then, as you know, there's cryoablation, there's RFA, IRE, and then there's intra-arterial therapies. And one that's really, becoming more popular is hepatic arterial infusion, where patients are getting a pump and they're getting 5-FU infused directly into their liver chronically to try to help systemic progression. Why does that matter for those of us that do local therapy? I think what it means is that, again, we're going to see more and more patients that have stable disease in much of their, liver, but in turn, they're going to have a couple areas that progress. And again, it's trying to come up with what is the best therapy for those specific use cases. What are some of the things? So, it's interesting. Even when I joined Northwell, there were still a few folks that, would say things like, well, you're gonna, and I mean this and that, Sanjaya knows, that you're gonna burn the liver, or you're gonna burn the ribs, and you're gonna cause skin toxicity. And I think it's important to just recognize that, as, just like Y90 today is not what Y90 was, 5 years ago or even a couple years ago, nor is chemo or immunotherapy the same. Well, radiation has also evolved. So, we already have what's called intensity modulated radiation therapy, where we can move the leaves of the fields and really focus in on the tumor. And in real time, as the machine's moving around the body, it's modulating that beam and allowing it to give a very conformal dose. We also have now protons, carbon, and I'm not going to get into a lot of detail on these, but I think the take home of these is that we have the ability to be able to it uses what's called a Bragg peak, which means that the beam of radiation goes in and it basically just kind of drops like a missile in the tumor, and you get a lot of dose in the tumor, but you don't get a lot of dose in the surrounding tissue. And that's really beneficial, especially for central lesions where you're really trying to avoid or retreatment, where you're trying to avoid treating more of the parenchyma, especially in patients that have limited liver reserve, and especially in HCC, for example, or in patients that have had surgery before. And then what I'm going to focus a lot about is either stereotactic body radiation, or otherwise known as stereotactic ablative body radiation therapy, now that we can get to much higher doses. And then also, it's not just about the type of radiation or how we can focus it. It's also how can we see the tumor. And I'm going to talk a little bit about MR guided radiation and what's called adaptive therapy, which means that in real time, we can now see exactly where the tumor is. And within seconds, we could treat exactly where we need to treat and make sure that we're limiting that allows us to have tighter margins and have a much lower dose to the normal tissues. Further, just like anything else, if you're trying to shoot something and it's moving around like skeet shooting, it's really hard to see it and shoot it. So what we want to do is control breathing motion, and that can be done by following fiducials. It can be used by compression. It could be used by breath hold. We want to be able to target it better, so we put now fiducials into the tumor. If it's up against the bowel, we now can put spacers and separate out the bowel from the liver, to allow us to, again, give ablative doses, whereas historically we couldn't. I already mentioned onboard imaging. And then what's also very exciting is using PET imaging or functional MR to be able to not only diagnose the tumor, but how we can better utilize that to assess response. And I think this is really a big part of the field, looking at radiomics and coming up with novel biomarkers to be able to assess response. And that's important because more and more, our patients are older, right? They have more comorbidities. And generally, we need to be gentle. We need to be careful. And being able to sort of assess response without being invasive or biopsying them is going to be really key for the future. So for those that aren't familiar as much with stereotactic versus conventional, when we talk about stereotactic, we're talking about giving a much higher dose per day or per fraction. We're usually giving it between 1 and 5 days. We're moving much more towards what we call ablative dose, and I'll get into that in a minute. It's also important that, we're being much tighter to the tumor than historically, which is good and bad. What that means is that, it allows us to, again, treat less of the parenchyma. But the downside is that, in some cases, we might have marginal misses, or we might have local recurrences that are just outside the field. And again, the technologies have allowed us to do this safely. On the other hand, conventional is where we're giving it usually over 25 to 40 days. And these are cases where we're trying to be more careful, like if the bowel is right next to it, and or the patient has other comorbidities, or they have very limited liver reserve. Or the other issue is that in some cases, if a patient lives in an area where you don't have all the fancy radiation, can you still get a high dose without having to put the patient at as much risk? So again, it just goes to show that even if you don't have an MR guided radiation platform, you could still give a high enough dose to still have a durable control. A lot of times I hear that people talk about, oh, that's much too big for radiation, that must be given with Y90. And I think, again, I just want to convey that, again, with technology, we can treat big tumors. I will say that, with the advancement of Y90, Y90 can, in a lot of ways now, be able to give higher doses than we can give. But I think the question is, as I'll get into, is how high do you really need to go? And I think that we're getting to a point where, sure, we can go to really high doses, but we need to be mindful of the short-term and the long-term toxicities that may be associated with it. And I think, just to take a second, if you think about Y90, you're giving Y90 through the hepatic artery, it's coming up. And again, when I say Y90, radioembolization, it's where you're giving, whether it's going to be glass beads or resin beads that come in. Usually the penetration of those beads only penetrate really a couple millimeters into the tissue. So basically, as you know, you're going to get sort of a ring, and it can treat this area. Now, in certain tumors that are not very vascular or that are very fibrotic, or if there's sort of extension outside of that region, sometimes you're not going to get the same penetration. And that's where sometimes you'll see marginal misses. And I think, again, in the future, it's how do we optimally maybe combine Y90 and then give a boost with stereo in regions where the interventional radiologist says, I just don't feel like I got good dose to this region, and then prophylactically give a boost with stereo. And I think this is the direction that we're going in. I just wanted to show you guys, I think everybody probably knows, but the fiducial use, moving more and more towards, more gold fiducials causes less noise and less, change in CT imaging that can affect response evaluation in the future. Typically, we put 2 or 3 fiducials so that in all dimensions, we can kind of co-localize where we're going. I tend to put these, I try to encourage to put them outside of the tumor. So, you can put them just adjacent to the tumor to decrease the risk of seeding or other complications, and also to allow better assessment of the tumor moving forward. I just wanted to show you a couple pictures. A lot of people were saying, what exactly do you do? Do you guys push the button? How does this work? And this is actually, one of the machines from MD Anderson. This is a CT on rails. The patient would lay right here. We would put the patient through the CT on rails, get pretty good diagnostic imaging, level imaging, and then flip it around and then turn the patient over, not turn the patient over, but just rotate the couch. And then it would allow us to then fuse that image with the planning system. And then this here, the gantry, and then this is the collimator, this rotates around the couch and then gives radiation. Now, when I first started as a resident, we typically would treat like from the front and from the back. We then did what's called step and shoot IMRT, where you kind of pick 10 angles that you shoot from. And now much more commonly, we're using ARC or what's called VMAT, where you're keeping the beam on the whole time that you move around the patient. I did have a video, but it kind of took too much space. It kept locking up on me. But anyway, the point is, the technology and everything is expanded to allow us to the other thing that's key is that we can now give these treatments in 15 or 20 minutes. They're non-invasive, and I think a lot of times, again, I'm very good friends with our IR colleagues, for those that are on, but they'll say, well, we can do Y90 in one treatment and we're done. And I think that's true. But, again, I think we can admit that there's some invasiveness to it. There's some risk. Patients can have some toxicity. And again, with patients who are very old or have a lot of other comorbidities, that again, the radiation is probably still the least invasive, and you don't have to put in fiducials if you could see the tumor, if you could co-localize it, or if you have image guided radiation. I mentioned, I just want to give you a quick example. We talk about breath hold. How does this even work? So you can see the block that's sitting on this patient's, belly/chest. And when the patient's breathing, you have this kind of video game set up at the console that allows us to see the patient breathing. This is the video of it. And then they wear glasses and the patients can see what we're seeing. And what we do is we set a goal for the patient to have the breathing right in this region. And then the patient will see it and they'll take a deep breath and then they'll lock in to this region. And they do this during what's called the simulation scan, which is exactly like a flight simulator. It's allowing us to get ready for radiation. And then the same setup is used for the actual treatment, where the patients will, again, take a breath, stay within this bar, and then we know that the liver is within millimeters of where we want it to be. And then, as mentioned, we then have onboard imaging that allow us to visualize the fiducials during the consult, during the radiation. And then again, there's several different ways that we try to minimize the error to less than a couple millimeters. The other evolution is we basically contour, we call it contouring the tumor. And what we're learning is that, here's an example of a liver tumor here. What we're learning is that if we can even get a very high dose to the core of the tumor, and then maybe even a slightly lower dose to the periphery, it could still be enough to be able to elicit long-term control in our patients. And that's important because, in this case, what you see is you have the stomach right here, right? And so what historically we used to say, well, the stomach's too close, so we can only give 45 gray, and that's it. We just can't give any more. But what we're learning now is that if we go ahead and we contour the stomach or the bowel, we expand that, we just then we pull back on the target just in that region where there's overlap. And then we boost the core of the tumor to a very high dose. We still give most of the tumor a very high dose also. And that's allowing us now to not compromise on our dose and be able to give an ablative dose. And that results, as you'll see, in some better outcomes. Here's just an example of what it looks like on our machine. So, this is our simulation. You could see, obviously, you could see a much better view here of the contrast. You could see the dense necrotic core of the tumor. And what these colors here represent the dose of radiation that we're providing. And again, you could see the green is going to be usually the ablative dose, a slightly lower dose, and then you could see the dose fall off to the rest of the liver. This is what it looks like on the machine. So as you could see, we can't see it as well on some of the machines. But again, as I mentioned, as we'll get into, when you have MR guidance or even better imaging from a CT perspective that is evolving, we can still see it pretty well. What are the kind of patients for HCC that we would want to be good candidates for radiation? And I think the most important thing is that, as we know, these patients have cirrhotic livers. And it's really, we have to be mindful that most of the patients, as I'll get into, are going to be your Child-Pugh A or B patients, early B patients. When you start getting into Child-Pugh C, that's where you run the risk of more toxicity, specifically what's called radiation-induced liver disease. And so kind of paying attention to things that affect not only, that influence and give us guidelines as to the status of the patient's liver. And then, I won't go through all these in detail, but, these are sort of the general guidelines that we pay attention to. And then just like the surgeons, for the surgeons on the call, we always talk about a future liver remnant and, you're going to be very careful not to take too much of the liver. We also contour the entire liver. And then we then contour the tumor. And then we say, okay, can we treat this tumor to an ablative dose, but still spare at least 700 cc's of the quote unquote normal liver to less than 15 gray. And if we do that over a 3 treatment regimen, we know that the risk of what we call radiation-induced liver disease can be kept less than about 10%. And so, again, we've gotten to be much more analytic in how we treat these tumors. Back when I was at Michigan as a resident, we really didn't know what we were doing. Really, we did a lot of studies and we were treating, big tumors to high doses. And I think now we have a much better understanding of how do we do this safely. So I'm going to give you a couple examples. This is an HCC case, a patient 2.5 years out, status post RFA. And you could see, as we talked about, in some cases, you get these sort of marginal recurrences that can occur. And this patient also had a tumor thrombus. And, overall, it looked to be a good candidate. The patient had decent liver function, Child-Pugh A5. Here you could see the tumor, you could see the arterial enhancement that occurred, and marginally around the RFA border. And then again, you could see the washout consistent with what we would expect. And then here's the actual plan. The patient was put on a protocol that I'll get into in a couple of minutes. As mentioned, we did what's called VMAT or arc therapy. We had the patient hold their breath. And then we put a 5 millimeter margin, which is called our planning treatment volume, which means that we contour the tumor, put a margin around it, and then we prescribed. In this case, I would call this not an ablative dose. This was on a clinical trial. This is a slightly lower dose than what we would give ablative wise, but 40 gray and 5 fractions. We talk about how much of that area we wanted to treat. We were able to cover 95% of the tumor to the dose we wanted. And as I mentioned, you could look at you can look at how much normal liver, a kind of a very quick check is also look at mean liver dose. So if the mean liver dose is less than 20 gray, that's another marker of making sure we keep the risk of toxicity low. And then you could see here, again, here's what it looks like. You could see we're giving most of the high dose here to the tumor, but then each of these colors is a lower dose as you get further away. And so admittedly, there is some scatter, but the scatter is a low enough dose that we're not burning the tissue out here. We're not causing undue toxicity. And then you could see pretty much, a lot of the liver is completely being avoided by the dose of radiation. And again, the dose here to like the stomach and such are generally not going to be clinically relevant. The other thing about this is, as radiation oncologists, we need to do better in terms of standardizing how we deliver our treatment. And so at Northwell, we have several different hospitals within our system that are treating. And so at Northwell, we do have what are called liver directives. And again, I want to make a disclaimer. So, please don't use these directly. These are just an example. But this is how within our treatment planning system, we have standardized, kind of what types of patients should we be treating? What's the prescription? What are the dose constraints we should be using moving forward? And then, what's the setup supposed to look like? So remember I mentioned the simulation, are we going to give contrast or not? Are we going to do a 4D simulation is essentially being able to look at where the liver is. So if we're doing free breathing, for example, it's allowing us to see, where is the tumor at the different phases of the breathing cycle. And then when I was at MD Anderson, we also had standardized approaches. And remember, I mentioned the last one was with stereotactic radiation given over 5 days. This is an example of where we're giving 67.5 gray or 6750 centigrade over 15 days. So that means that every day the patient's getting 450 centigrade. And again, as you can envision or imagine, because the dose is different, right? Even though it's a different dose over more fractions, as I'll get into, the biological equivalence of it is actually pretty close. But we have to have obviously different dose constraints to be able to still be safe. And so these are all much more defined than they used to be historically. And so this is another example. This is, as mentioned, this is given over 15 days. It looks very similar from your perspective, but why would we do this? We do this if we were, let's say the patient got Y90 over here before, or let's say the patient has maybe Child-Pugh B, so we want to be a little bit more gentle. Or if, let's say if this is like a intrahepatic cholangiocarcinoma case, and we want to treat, the nodes and such, that allow us to even then expand this dose and treat the nodal volume to maybe a lower dose and still encompass all of the disease, which is something that you can't really do with Y90 or ablation. So this allows you to treat the tumor plus the nodal disease and hopefully result in longer term control. And again, this is called the dose volume histogram. What you see here is the dose of radiation. This is the volume of everything. And each one of these lines represents one of the structures that we circle or contour. So what you want to see here is that this is the tumor plus a margin called the PTV. It's showing that 100% of that volume is getting the full dose. But then you could see everything else is getting a much lower dose here, showing that it can be done safely. The other thing is that, this is a couple cases I just want to show you where patients have PET imaging, and it shows that PET can be a really nice way. So this is a patient that had RFA and TACE before, had TheraSphere, and yet, we were able to still treat safely by using PET and other imaging to focus the radiation. Here's an example of a tumor thrombus. And again, some of these can be challenging to treat with Y90 or other mechanisms. And surgery obviously would be very hard here, especially with the heart. And so I think these are really great cases to integrate stereo into the multimodality approach of care. The one challenge though with radiation is, to be honest, is that since we haven't been doing it that long and there's not as much experience, a lot of the radiologists don't really understand how to read it. And this is just showing you that this is a patient that got radiation. And then you could see at 3 months, you would say, wow, it looks like there's still disease there. And then at 6 months, you could say, wow, it looks worse, right? You're like, it looks like it recurred. It looks like, it didn't work. But what this really is just the change, that the tumor and the parenchyma is in this case anyway, it's actually recovering. All the, inflammatory cells have come in, the fibrosis is kind of resetting. And then you could see at 12 months, it's actually, pretty much gone. It's been resolved. So I think I just want to say that, it's very important to understand that it can take months to years for the full effect to be realized with stereo. And I think this goes into, I'm not going to get into a lot of example, but LIRADS is obviously what we use now to really define staging for HCC. But really, there's a couple papers that are evolving and such about how do we have standardized criteria for assessing response to high dose Y90, to high dose SBRT. And I think this is an exciting area in our field as we continue to learn together and having true dosimetric, and dosimetric meaning, I think the future is where we have, we actually are looking at the patient's liver on multi-D tumor boards, and we have like a roadmap of, okay, over here they got Y90, over here they got this. And in one image, we have exactly what's going on with that patient. So, in summary for HCC, I think the future is partnership. It's every case in my mind should be discussed, and we should be open-minded with each other. I think there's still a little bit of competitiveness sometimes. And it should be just, we should all be humbled by the fact that it's good that we have more therapies than we need, perhaps. Actually, not that we need, but more therapies than we probably know how to use, and that we should all continue to educate each other on these therapies and combine them in cases where it makes sense, and not try to do it as an independent physician. I realize I'm already a little behind, so I'm gonna just go through a couple. I think what's kind of cool about this, and I'm happy to share these slides, is I started looking at what are the guidelines? If you look at ASCO versus ASTRO versus the IR, or the American College of Surgeons. And it's so interesting to me because they're all so different, And so I won't go into a lot of detail, but, it's very interesting to me. Like, for example, some of them will completely leave out a modality. And then some of them will honestly not even, or mention them in a way that I wouldn't think of it. So I won't go into detail, but I think it's worth looking at and just kind of recognizing that I don't think anybody has the right answer right now. And again, teamwork is key. This is a little bit outdated slide. This is from Laura Dawson, who actually was one of my first attendings when I was at Michigan. This is just showing you that, again, when you're looking at Child-Pugh A, B, and kind of getting further along, that there is a role for radiation. And I think a lot of people don't recognize that SBRT can be very effective as a bridge, especially in patients that don't tolerate other treatments like TACE or have a lot of toxicity, to chemotherapy or Y90, that it's actually very effective. I'll get into that. There's not as much data, but it definitely can be used. It can be used where, again, patients can't get TACE or Y90, or if there's a lot of portal invasion, or I mentioned lymph nodes. And then even in the symptomatic, if patients are kind of end stage or they have complete obstruction of their biliary tract, sometimes, radiation can help relieve some of that obstruction. Here's kind of a quick example. I kind of follow this a lot of times to just sort of get a ballpark criteria of which patients are suitable, which ones should we probably not touch, right? Because I think some people are like, oh, of course I can do it. You can always give radiation, it's not always right to do it. And I think these are the cases where, unless it's palliative, I don't think it's a good idea. So you're going to hear a lot with the radiation oncologists where they're like, oh, I'm giving a biological equivalent dose, right? Well, what does that really mean? It really means that we're going to give different doses or fractionations of radiation, but at the end of the day, it's a measure of the true biologic dose delivered by these various combinations of dose and fractionations that we're discussing. And again, it's dependent a little bit on, or a lot of it, on the type of tumor it is, as well in terms of, how quickly is it replicating, how resistant is it to the tumor, as well as, it's taking into account also the tumor microenvironment, the vascularity, the amount of fibrosis. And to be upfront, I don't think we really know all the details we need to know. And this is such an exciting area for future evaluation, especially as we start bringing in immunotherapy or radiation sensitizers like PARP inhibitors. I think we're just scratching the surface about, how we can combine. And I think this is also relevant for Y90, right? So if you're giving 300 gray or 400 gray, what dose do you need to get to kill a tumor? And I think better understanding how resistant, et cetera, the better, the better therapeutic ratio that we can get to in these tumors. This is just an example. I just want to show you again, for those who are like, well, there's no data out there for radiation. No, there's a lot of data. It unfortunately lives in the radiation literature, a lot of it. But I think what's interesting is if you look, it's not bad, right? If you look at using 3 to 5 fractions of radiation, the local control rates are pretty decent. And I would say the survivor numbers mimic others. And so, I would just say that, it's a decent option for local control. And in HCC, if we don't control the disease, patients can die of local progression. And I think that's really important to remember. And as I mentioned, there's a lot of different ways to look at it. So there's good data out there for HCC. A lot of it gets combined with intrahepatic cholangio because in our world, they're similar in how we would approach them. But again, I think the key here is that the local control with protons and the survival is looking decent. And as we get to higher doses, I think it's going to continue to improve. And again, as I mentioned, local control matters in this disease. People are like, well, it doesn't really matter if we control it, et cetera. But no, as you can see here, as you get to this higher biological equivalent dose, even though they're small numbers, there's definitely an improvement in local control. And there's at least a signal that we're seeing better survival. And this is an older paper, and there's more papers. There's actually a cancer paper that Dr. Coy just put out recently on NCDB data. And it's pretty compelling that as you look across the country now, with higher doses, we're seeing better control and better survival. And this is one of the kind of analyses that MD Anderson has put out. And I think you see a similar trend and theme that higher doses result in better outcomes. Just so we're aware, what is the, let's say the cooperative data that's out there. This is really the main study that we have in our field. This is RTOG 1112. And it was failed initially partially because of the sorafenib issue, where people got sorafenib or SBRT. But the long and short of it is this study is closed. We did treat a lot of patients. I think there's going to be a lot to learn from this study, but it's not published yet. The other thing I just want to bring up is a lot of times people will say, well, I can just do RFA, right? And I think that's true. I think if it's peripheral, it can be easily done with RFA, but RFA still is a little bit invasive, right? There still can be some pain and some other, complications. And I think that what we know is that, again, radiation for small lesions can be quite effective. But I think what's also important is that you could see here, there's literature that if the tumor is larger than 2 or 3 centimeters, that actually stereo has been shown to be superior. So again, in your practice, if the tumor is larger and peripheral, it might be even easier just to give them radiation over 3 to 5 days as opposed to ablation. Alternatively, what we do a lot of times in our practice is we'll say, why don't you go ahead and RFA it, put a fiducial next to it, right? Just since you're in there. And if it comes back, 6 months or a year later, we can always just go ahead and give radiation in the salvage setting in that case. And that way it's the option's there if we need to do it. Similarly, if you look at this is a study from Michigan looking at TACE and doing a comparison of TACE, looking at local control and also liver progression-free survival. And again, this is not meant to be a competitive thing. It's just meant to acknowledge that, the data looks pretty compelling. And so, being aware that it's an option for your patients. And then finally, there's a paper that we published a couple of years ago now. A lot of people say, well, there's not much data out there on using SBRT for a bridge. And just wanted to acknowledge that this is a NCDB analysis where, most patients did not get radiation, a small number got radiation. And you can see that a lot of those that got radiation also did receive TACE. And actually the bridge to transplant was decent. You could see that there was, and this is despite the fact this is small, but I will just acknowledge that if you look at the numbers, this tumor size was larger with the SBRT group. And despite this, the toxicity was actually higher in the non-radiation group than the radiation group. So people would say, oh, radiation before transplant causes lots of toxicity. In fact, it doesn't. The morbidity and mortality was less, even though the patients with radiation were more advanced stage than those that didn't get radiation in the transplant setting. So in summary, I think just to acknowledge that SBRT is another tool in the toolbox that you could use for these patients. The technology's come a long way. Clearly in early stage patients, it's very effective. It should be considered, in generally smaller lesions with less, because when you get to be above 3 lesions, you start treating a lot of the normal liver parenchyma. And again, either doing it in partnership with TACE and Y90 is ideal. 15 fraction regimens are helpful when you don't have the technology available, or you're trying to be more gentle. And again, more data coming. I'm gonna go over this a little quick. I'm just gonna switch gears to just acknowledging that, and for metastatic disease, again, a lot of us are managing more metastatic patients. A lot of them are having steatohepatitis and specifically colorectal metastases. These patients are now living a much longer time period. And I think because of that, it just, again, raising the awareness that SBRT and radiation, just like this, as you could see, it's sort of a similar story, that we have a lot of things we could use, and we just need to continue to work together to use them appropriately. I think a similar theme, but actually more important, is that, again, the BED matters in metastatic disease. This is an example from a couple different studies showing that when you get to higher doses of radiation, the local control becomes much more durable. And I think the take home here is that when you look at HCC generally is a little bit more sensitive to radiation in general. A lot of metastases like colorectal, liver metastases, we generally need to give 20 to 30 or even 50% higher doses from a BED perspective to get a more durable control, especially in heavily pretreated patients. There's a similar theme here, and I won't go into detail, but just if you look here again, if you're doing RFA, tumors greater than 3 centimeters, you have 7 times more likely to fail. But with SBRT, you actually have superior local control. And so again, it's just show that if it's a larger tumor for metastases, colorectal metastases, that SBRT is quite effective. Now switching gears and talking about some of the toxicities. This is a review paper that we did, again, a couple of years ago, outlining some of the toxicity with the newer radiation. And I think what you could see is there are a few outliers, right? You could see that there's a couple examples where you have patients with grade 3 toxicity. I think a lot of that is going to be larger tumors, again, patients that kind of hover on the B/C criteria, but very few patients have grade 4. The toxicities, are generally self-limited, and patients typically are going to recover. But the devil's in the details, again, the amount of normal liver that's left behind, the size of the tumor, and I would say just, again, the burden of disease that the patient has. One way of addressing this in HCC is by using individualized adaptive radiation. This is a really cool study out of Michigan, where what they did is they did ICG assessment, which is a novel imaging agent. They would then treat with 3 doses of radiation and take a break. And if there was adequate liver function based on repeat imaging, then they would go ahead and treat as planned. But if there wasn't, they would pause. And what's interesting is even in those patients that only got 3 doses of radiation, I won't go through all this detail, but even those that got just 3 doses of radiation had pretty great control, acknowledging that maybe we were sometimes over-treating these HCC patients, and that by doing kind of this adaptive treatment, we don't maybe need to do 300 Y90 or 300 grade Y90. I think it's acknowledging what is that sweet spot of what we need to do to get good outcomes. And again, even with the lower doses, there wasn't much of a difference of control. So how do we actually evaluate the dosimetry? So how do we know what was actually given? And I think this is the future with Y90, or with SBRT, is we have to have ways. And so, for example, with Y90, doing Bremstrong imaging right after Y90, you could see some of the release of the beads, radiation that could be picked up by the camera. And then, like, okay, this is where the dose was delivered. Okay, it's still not a science. I mean, it's a science, but it's not perfect. Similarly, you can do after radiation, or if you know that, like, let's say there was ablation, if you do SPECT imaging or PET imaging, you can typically see, this is the area that's necrotic or dead or non-viable, and then this is the area that's viable. So this allows us to more readily understand what is the actual viable liver. And that's important because when we're doing our analyses, we want to say, okay, in this case, for example, if there's a tumor now that's over here, and I want to give an ablative dose, I can then calculate out what's the true remnant. Like if I include this area in my quote unquote viable liver, clearly that's not accurate. And that puts my patient at risk of more toxicity. So again, the novel imaging, I think, is the future. All right, so a couple slides just on future, and then I'll have some time for questions. I'm really excited about, I think the immunotherapy has already shown some exciting work. I didn't get into that here, but even immunotherapy alone before surgery, we're seeing complete responses. These tumors are just melting away, but not all of them do. And I think, this is one study that just sort of, they looked retrospectively at those that got radiation and nivolumab for HCC. And what was interesting is they found that they looked at two different groups, those that got upfront radiation prior to overlapping with nivolumab, and those that got salvage radiation 4 weeks following, right? And what you could see is that those that got the upfront radiation seem to have a little bit of a better response, meaning that, even though there's not a so-called abscopal effect per se, abscopal effect is where you're giving radiation to one area, and then you're seeing an immune response in other areas. What we are seeing is that maybe giving radiation up front results in a more durable or a more robust response. And, the question is that because the immunotherapy can penetrate the tumor better? Is it that it causes antigen presentation? Is it because it attracts immune cells to the tumor? There's a lot of research being done on this, but again, I think there's still much to be learned. But again, you could see that those that did respond, and you can see again, upfront radiation did result in a better response ratio. So again, these are things to think about if you have a patient that has a large tumor and you're trying to combine it. And I think there's interesting work in this for TACE and Y90 also. So it's not just limited to SBRT. And then I mentioned MR guidance, and I think what's really exciting now is that we can push the dose even more, because on the machine we can now see exactly where the tumor is, exactly where the bowel is, for example, and it gives us more confidence now that we can give higher doses. And what you're seeing is really impressive survival numbers with these higher doses of radiation across the more modern series of studies that have now come out. And the last slide before we open it up for any questions is, so I was asked by Andrew Coe and the GI Steering Committee to put together a NCI task force working group to develop the next clinical trial for pancreas cancer. And essentially, it's a very busy slide, but I'll explain in a second, is that I was asked to sort of put together some working groups to say, okay, what do we need to learn about radiation in pancreas cancer to develop the next trial that, to help cure pancreatic cancer? So first of all, is there a role in radiation in pancreas cancer? If so, what do we need to learn or put together to create that trial? And so what you could see here, and the reason I show this slide is because I think you could see some similarities in terms of, what we would do for liver. And so there's, it's sort of, if we're going to do surgery after radiation, what are the things we need to think about? The dose, do we treat nodes or not? What is the volume we need to treat? And so in pancreas, these are the two leads that are each of these leads has 15 people in it. So we have 15 people in each of these groups addressing these areas, doing a comprehensive lit search, summarizing the current data, and then using that data to drive the next clinical trial. And the thing that's cool about this is it's rad-onc, med-onc, surg-onc, IR. It's not limited to just radiation oncology. And so we're also looking at how do you standardize radiation? How do you select patients for radiation? And then what are the novel combinations? And I think you could almost replicate this for liver. And in the novel combination group, you could say, what about immunotherapy? What about Y90? What about, TACE? And so I think as we evolve in a field to treat HCC and liver mets, it's imperative that we work across our disciplines, across cooperative groups, and really try to drive the field further faster. And so with that, I just want to say, some people were kind enough to share slides with me. This is my email.